Hello, everyone, and we saw about anatomy, and we just saw about the countries of the world. So previously we saw about anatomy, physiology, and biochemistry. So now, the second year, pathology and pharmacology and forensic medicine, and I'm just recording it. I'm not going on live just because I'm taking some rest. Just having some rest for a few months, and then all of the things. So like uh, and quite the light is somewhat less, but I prefer the situation and this color, so that I could talk more about things. And it's um, a lot of things to say, and what to say, it's the second year was very nice, and pathology, actually I had three times of uh, arrears. So I just passed only on the third time. So it was just unimaginable even now, that like uh, I could not get through pathology. But things are okay, and so then was my pharmacology. So I have taken the essentials of medical pharmacology, KD Tripathi JP book. So that times during 2010, I was feeling very much. Actually, for a period of 6 months, I was feeling very much chill and cold, just because I was traveling along the iciest, coldest part of Kashmir, and so I need to travel for a distance of about some 10 kilometers along Kashmir Road, so that because I took my bike from that time, because there was a road construction work was going on. This like what to say this bridge construction work was going on, so that and also the buses, I was not very happy with it. Likewise, there was a lot of the people were happy with the bus. There were a lot of um, uh, crowd, but it was okay. But I preferred my bike by my own choice. No one compelled me. I just asked permission from my mother and my father and took my bike. Because I was getting late in the morning, I had some nice sleep. Um, and also, what to say, my first experience with the Dhaka road, the Bangladesh, the Pakistan, and the Kashmir. So was after a few distance away from the city, I was feeling quite nervous, but not too much. No, I was not afraid. But moving on, I was feeling lonely, but reached the destination and had some nice time, because I was familiar for 1 year, and I know the routes and the roads, so was familiar. So the second year was very memorable, and pharmacology also I need a second attempt to pass, and it's not like what to say. Uh, it's not an achievement, but it's a failure. So then, so like um, I think I was reading on pharmacology actually. No, I just don't remember what I talked about. But I was talking about anatomy and physiology and biochemistry. So this pharmacology has these things, and so this pathology has same kind of things. So and I not talk about pathology also, and so just because first year I finished with 1 year, and this second year became trouble, so that I could not continue my third year. So I was not able to attend my third year exams. Likewise, I was attending the classes of third year, but I was not able to get into my exams. So a bit of confusion. So if that you have told me about things. So if the attendance is present only, you will be allowed to the exams. Then I would have certainly not put in the attendance. But what happened was people along with me was just saying to me that this was just because there were only one or two attenders to me. So like everyone were not aware of, but I don't know how many of them. So there are people who still have not passed in pharmacology, just because they are writing this MD pharmacology. So I'm not writing MD pharmacology, but still I must be given an equal grade to MD pharmacology. So that is a must. So I have to give my best out of it. So that's why I was made into arrears, and that also I was very much worried about. So I would have not put in my attendance to ophthalmology and community medicine and this ENT because I need to complete my section of work with what I have learned and joined. And also there were things such that I was not remembered about people along with me. So my school people, they were to the engineering college, a few of them. So I know only them. Others were from representing different countries and I mean different regions in Tamil Nadu and all of that. And so again, when got a transfer to Dhaka, again, there were confusions. They also got transferred, but representing different parts of the Tamil Nadu and different parts of India. So there were also a confusion about who is who and where is who, and so there was a scattering and there was not a togetherness, and the followed togetherness was slowly scattered, but still together only. And it's we have general pharmacological principles and drugs acting on autonomic nervous system and autopoietin related drugs respiratory system drugs, hormones and related drugs, and drugs acting on peripheral somatic nervous system, drugs acting on central nervous system and cardiovascular drugs, and drugs acting on kidney, drugs affecting blood and blood formation, gastrointestinal drugs, antimicrobial drugs, chemotherapy of neoplastic diseases, miscellaneous drugs. So pharmacology, I read this Shenbach, Taravi Shenbach, and this book. So the first term I read this book, and after the next year, second term I read this one. So then, um, but I'm not sure that like I was not given any special preferences. Everything was going along with the people, and but I gave my best and I did my best to make a contribution towards the department. So this was a great confusion with pharmacology. So the drug names are already different names, and again the author has written along with the scribbling of his own thoughts. So that also was, but it's a language problem because the author has see like I'm an actress. Consider I'm an actress. I have to act in different languages. So in a day there are more than 125 channels which run regularly. So in the television, so about in TAC TV there are about some 500 channels. So there are about some 50 languages, and so as an actor, so if there is dubbing also, I have to act in about more than 10 languages per day. So the author is very much concerned about his language. So that's why we had a confusion also. It's okay, we'll keep it for a future, no problem, because what we work is to earn and to lead a life which helps in the future. And and about the coronavirus, I'm not sure about anything because I'll get into microbiology and say, but microbiology also second time earlier. So I read two books. So and like so it's already 13 minutes now, and so I think I could go into introduction and say the stories as by as, because no time for stories. A lot. See how much big. So see the pages, how much big book, and so the pages are about some 1,000 pages, and so approximately 900 pages. So pharmacone, logos, crude natural products, and limited efficacy, Rudolph Vachen. So today morning I was learning about this pharmacology, some first two chapters, because I'm not at all certain about the drugs and the action. Then only I could prescribe the drugs, but not even certain about where it acts, what is the H plus ion, what is the Cl minus ion, and what of that, and all of the actions and the diagrams. While learning itself, you must have made us practicable with that. Um, just we can't get a pass with what all of the students present as a paper. Um, so then we have this Rudolf Buchem, Oswald Spiegelberg, father of pharmacology, and we have what the definition, pharmacodynamics, and So the adrenaline, G protein, cyclic 3, 5-AMP, pharmacokinetics, and we have paracetamol, and absorption, distribution, binding, localization, storage, biotransformation, excretion, and 30 to 60 minutes of levels, and 5 ml per kg per minute, and we have the sulfate conjugation, and we have glucuronides, and 2 to 3 hours, and diagnosis, prevention, treatment, cure, and we have physiological systems, pathological states, benefits, and we have addictive, abused, illicit substances, and that we have the pharmacotherapeutics, and we have clinical pharmacology, that is the evidence-based medicine. Then we have chemotherapy. So we have the systemic infections, malignancies, and all of that, and we have selective toxicity, and pharmacodynamic agents, chemotherapeutic agents, pharmacy, and we have dispensing drugs, and the collection, identification, purification, isolation, synthesis, standardization, quality control of medicinal substances. Then we have this pharmaceutics, so it's a technological science. So then we have toxicology. So we have detection, prevention, treatment of poisoning, study of adverse effects, and so we have the drug nomenclature. So chemical name. So Mr. Tripathi is to say about Akeri Tripathi. Um, so is a MD, ex-director, professor, head of pharmacology, Maulana Azad Medical College, Nasir Ellen, GB Pant Hospitals, New Delhi in India. So it's a JP Brothers publication, and so um, then we have a preface, and so I think my uncle has written this. So so we have this drug nomenclature. So we have this chemical name. We have the example: 1 isopropyl amino, 3 1 naphthyloxy, propen-2-ol for propranolol. So then we have a code name. So that is example is RO 151788, later named flumazenil. So these are from extractions and the name codes, and non-proprietary name. So we are having this United States adopted name, and we have the BAN, the British approved name. So we have the recommended international non-proprietary name, WHO, and we have examples are meperidine and pethidine, lidocaine and lignocaine, and we have the approved names and the official names. So etymologically, these are like phenothiazidines, tricyclic antidepressants, aminoglycosides, antibiotics. So this is a misnomer, and official parlance. So then, so that time I have underlined even this official parlance, just because I don't know what is what. And so then we have this altol, altacardil, aticor, aten, bitacard, lonol, tinolol, tinormin, and the proprietary and the brand names. And so they are catchy, short, easy to remember. So I just had some dopamine effect. So a Parkinson's disease with this pharmacological book. So Timolol Malia eye drops. So what he's saying is just pass by whatever you think out of the words. And so we have Timoptics in USA and Glucomol in India, and much confusion in drug nomenclature. And then we have uniformity, convenience, economy, better comprehension. The author is feeling very proud that every 100 of the people are reading this book, and so quality and bioavailability. So make sure you buy a book to yourself, don't borrow. And mm, and we have this public health relevance, evidence and efficacy and safety, and cost effectiveness. Cost effectiveness is such that you can have money, but you should not refuse having it. So then we have multitude and congeners. So and all of the things. Then we have first model list of essential drugs and national list of essential medicines. There are 354 medicines. Um, then we have um, orphan drugs. So these are sodium nitrate, fomepizole, liposomal, amphotericin B, ancrod, rifabutin, succimer, somatropin, digoxin, immune fab, and leothyronin, and many more. So then there are routes of drug administration. So we have factors governing choice of route, and we are having local action and the systemic action. So the local route is that their example is glycerin trinitrate. So it's an ointment or transdermal patch. So then we have the tropical. So then we have non-absorbable drugs and such as sucralfate and vancomycin and jellies, so powder and iodine and topical medication. And we have the deeper tissues, syringe and needle, intraarticular injection and infiltration, and the intrathecal injection, and we have retrobulbar injection, hydrocortisone acetate, for example. So we have the arterial supply. So it's an intra-arterial injection, so it's used for contrast media and angiography, and for anti-cancerous drugs and brachial artery for limb malignancies. So we have the systemic roots and this. So I've given update virus protection. So Windows is asking for it, and so it's already 21 minutes. And so the systemic routes, we have this oral limitation of oral routes of administration. We have sublingual or buccal, we have GTN, buprenorphine, desaminoxytocin. Then we have the rectals and all of that. So we having retention anemia, enema for systemic effects, and we have inconvenient and embarrassing, and we have diazepam solutions in the external hemorrhoidal veins and the internal hemorrhoidal veins, and we have irritant drugs for rectal inflammation. We have diazepam, indomethacin, and paraldehyde ergotamine. So we have next is cutaneous. So for rubbing the preparation, oily base and occlusive dressing. We have then transdermal therapeutic systems. So we have stratum corneum, rate controlling micropore membrane, and we have adhesive impregnated, and percutaneous absorption circulations, and constant and predictable rate, and usually in the chest, abdomen, upper arm, lower back, buttock, mastoid region, and all of that. There's a picture, nice picture given. So intranasal spray is given sublingual tablet and intramuscular injection, intravenous injection. So it's quite scary about the intravenous injection. So I had one intravenous injection during my last times. So previously in 2018, 2017. So one patient in ortho department, I think. Not orthopedics. I think ortho or medicine. So that patient had a inflammatory vein in the arm. So every time when they inject, the vein becomes bulged. So that time, what happened was I was one crooked person, so to say. always be with tension, hypertension in the department. So, in the evenings, I just need to get home or go to my room, or just need to get to sleep or be with wind. So inside the department, I don't believe in living. So that time, what happened was there was one patient, very slim patient, thin patient, a lady. So she had this inflammatory vein, and so I was just scanning around her arms. So I have a scanning eye. So just like after having a uh, like uh, scanning practice, so I had a scanning eye. So then what happened was, I just took her arm. I just before palpation, I used to examine through the eyes, such that I find nothing different. But this lady's arm was, I just found out. She was her hand was bleached fully, and what to say, belched, and so her nerves were very thin. I could just know her veins were just like nerves. So I could just not insert the needle into the vein, and could not find the vein. But after giving her some dose of like Taximo, I was giving. After giving her 500 milligrams of Taximo, I have to give to her. So then, after giving her the dose, just some 500 milligram, I took in a syringe, and so actually that 500 milligram I have to mix with solution and give it to her. So then what happened? I mixed with the solution and took some 10 ml. So after 1 ml, her veins started bulging. So, like usually, the bulgement with the veins will be very smaller. But this lady, the bulge is starting bulge for 1 ml was this much big. So I just got confused. What this is a syndrome, maybe a cardiac syndrome. But then okay, slowly and slowly, I was giving the infusion. After the 10 ml, there was a small bulge. Then there was a suppression, the bulge got smaller, and there were absorption, and again there was a bulge in the nearby area. And so usually when it goes into the veins, there won't be bulge, like only one area there will be a bulge, but in the nearby area also there's a bulge. So then I thought it's not a problem of the veins. Then I just gave into 10 ml, then some 15 ml was there, I think, after mixing with NSO. So and I was giving her, she had severe pain with the hand. So she was she had a syndrome with the nerves. So usually we have this club foot, and this what is it? This Oh, my friend has come. So we have this palsy in the hand. So we have this what to say, this some palsy for the hand, and we have this what is okay, she had this nerve problem with it. And also there was a problem with the tendons of her hand. Actually, the legs have a tendon, for the hand they have a tendon, or yeah, if there is a muscle there'll be a tendon, but I don't know, she's not having a muscular syndrome actually. But to an extent, she's having problem with the nerves. She's having neuralgia, neuralgic pain is there. But her veins are very much intact, and they are very much firm. And how come these veins become like that? But no, congenitally, by birth, they don't have these veins. I mean, very tough veins like arteries. So, but I'm sure I have not inserted into the artery. Usually, veins are only on the outer surface, on the to say it as the medial surface. So then what happened was, she had some pain. She was like closing her eyes and was like making some sound. She was shouting. Um, but I said, so I was just giving some massage on the top of the vein, just moving on. Actually, it was taught by my co-friend, my junior, so that the patient doesn't get pain. You must just make a gentle massage on the top. So then I was giving up. So I had to put the Venflon first. So I did not get the nerve. Her nerves, the her veins were empty. So uh, and then what happened was I put on the Venflon also. I got a vein and put on the Venflon on the front, and so then usually on the front they don't get if you don't get a vein, they put on the nearby of the thumb, so they get some nice vein there. Actually, it's good, you get a nice vein near the thumb. So since most of the people who have this club syndrome have uh, vein supply in the thumb. And but we must be very much sure that we remove the Venflon after injection, so that don't get injured by movements. And so after because I was not in a hurry, I had my food and all of the things. And I had some I had some scoldings and had some bad name with the um, uh, department, what to say, the HODs and the chief. So the department chiefs, and we have some divisions like M1, M2, M3, M4, S1, S2, S3, S4, and Ortho 1 and Ortho 2 and all of that. So we have each department division has a chief. So then I had some complaints about I was not regular, or I'm not attending the patients. But most of the patients I attend are very serious cases given to me. So these cases are very hard for even the chiefs to handle. So these cases were mostly given to me, and I myself was not aware about that I am given I am wantedly given those cases, because not for some vengeance or that, I am given for some practice. um, so like and So it all went by. And happily I finished my work, but I was that day fully I was thinking about that lady. uh, like um, she was fine. So the next day, morning 6 o'clock itself, I went. Then actually 6 o'clock there is about some 1 o'clock or 2 o'clock in the night there. But how do you manage to make that time in the morning? Uh, and so that was also actually, in the morning 6 o'clock and all, I'll be having a severe sleep. Just because I was brought up regular. Because the rules are very much strict in the British. So you would have heard about the kings and the queens and all of the people who go to regularly at bed, who have a regular dining time and sleeping time. So even after 6 o'clock, if I sleep for 1 hour till 7 o'clock, I'll be happy. And for the whole day, if I blink, also it will be very much happy sleeping with that early morning chills. So that morning I went. So my friend removed the Venflon and put it in the other hand, but still the patient had the same vein inflammation. So so this diagram, it is like a vascular pathway of drugs absorbed from various systemic routes of administration and sites of first pass metabolism. So we having this, and we have transdermal patch. So then we have first pass metabolism in the lungs, and we have sublingual tablets, and we are having first pass metabolism in the liver, and we are having the oral tablets in the stomach and the portal vein, and we are having the first pass metabolism in the intestinal wall, and we are having 50% subject to first pass metabolism, and we have the suppositories. And I have written something nice. So we have total. So there's a note given. Total drug absorption orally is subjected to first pass metabolism in the intestinal wall and liver, while approximately half of that absorbed from rectum passes through liver. And drug entering from any systemic route is exposed to first pass metabolism in the lungs, but its extent is minor for most drugs. So we'll read the note once again. So this is something related to the pathology. So it is like um, um, total drug absorbed orally is subjected to the first pass metabolism in the intestinal wall and the liver. So the intestinal wall and the liver. So the first pass metabolism. Half of that absorbed from the rectum passes through liver. So from the rectum, half of them passes through the liver. Drugs entering from any systemic route is exposed to first pass metabolism in the lungs. Um, so, but its extent is minor for most drugs. So, so in the lungs, okay. So I also not still aware such that. So I have thought that the systemic route, the drug entering the systemic route directly enters the liver, but it enters the lungs. So is it the statement true or false? So I have a doubt about it. So its extent is minor for most of the drugs. So only a few drugs extend up to the lungs, and um, okay. So what to tell about this is This is somewhat a systemic side effect representing diagram such that half of the rectum absorbed reaches the liver. So the drug half from the rectum reaches the liver. So individually, most of the drugs through entering the stomach, so there is some anatomical portal system, and so then like actually the lungs, do they have the effect of the drugs? So how do they give it like so actually if it enters the liver, it enters the circulation through the blood, but when they are through the systemic, uh, they enter directly to the lungs. So only a few of the drugs are needed by the lungs for its function, and most of the drugs are needed by the liver for distribution. And so a part of the drug, if absorbed by the stomach, the intestinal wall, a part of the drug stays in the stomach, and the remaining is sent through the circulation to the liver and absorption and all of the things. So it's a very nice diagram, and also resembling the human pathology. So then we have this cutaneous. So we have rubbing the preparation, oily base, and the occlusive dressing. Then we have the transdermal therapeutic system, and so we have the stratum corneum and all of the things, rate controlling micropore membrane, and we having adhesives and impregnated and percutaneous absorption into circulation, and we are having a constant and predictable rate for that, usually in the chest, abdomen, upper arm, lower back, buttock, mastoid region, and transdermal patches of GT and fentanyl, nicotine, and estradiol. So we have this isosorbide anhydride, and we have iosin and clonidine. So then smooth plasma concentration of drugs without fluctuations, minimize interindividual variations, and we have local irritation and erythema, and we have 2 to 7% of cases. So then we have inhalation, then we have general anesthetics, and we having alveoli and all of the things, and so we have the moment to moment adjustment through inhalation, and we have irritation vapors, ether, inflammation of respiratory tracts, and all of that. So we have illustration of transdermal drug delivery system. So there is a picture. So we are having backing film, we have the drug reservoir, rate controlling micropore membrane, so adhesive layer with priming dose, and we have the capillaries. So what happens to the skin? So usually if you read about the fish pathology, so you see the skin and all of that. So this is the absorption of drug through the this previous picture was absorption of the drug to the oral and the rectal routes. There are only two routes to the stomach and the intestine. So then we have the third route of drug absorption. Not only drug, all of the watery substances, the food, and food-like substances for the skin. So then we have this fishy skin mechanism. So usually consider the skin as a human skin as a skin of a shark or a skin of a whale. Usually a shark have thick skin. So, so there is a backing film, there is a drug reservoir, so there is a backing film. So this film acts as a supportive one. So it doesn't let anything outside except for the pores. If any drug or poison is absorbed to the skin, it doesn't let outside. So this backing film is the skin of the shark or a whale. So consider shark. So then consider dolphin. It has a thick membrane. So then we have this drug reservoir. So there's a reservoir beneath the skin. So the reservoir decides whether to let the drug inside or let it out through the pores. So if this reservoir membrane is intact, or like it is out of nerves, then what happens? Drug is directly absorbed into. Nothing will be let outside. So if there is loss of nerve supply or something like that, so everything remains with the nerves, and so whether you live or die. Next we have this rate controlling micropore membrane. So there's a micropore membrane, porous membrane for filtering the drugs into small doses so that it is absorbed by the adhesive layer with priming dose. So there is an adhesive layer. So there's a micropore and an adhesive layer, sticking layer. So that this adhesive layer sends inside the drugs properly, evenly distribution. Then we have this capillaries. So these capillaries take it to some extent of the nerves, I mean the arteries, so that the drug has some extra effect. So next we have um, this nasal and parenteral. Then we have this gastric irritation, vomiting, and the liver is bypassed, and invasive, painful, subcutaneous, and the nerves less vascular. Shock patients who are vasoconstricted, and we have the depot and repository, and we have the dermojet. See, there are new things and the pellet implantation. So these new things, you should not try it by your own. You should go and visualize what they are doing, how the presenter, the inventor, or the communicator is presenting with the uh, product, and you should try it on trial once or twice, and then only you are experienced. So then we have this microfine orifice, gun-like implement, and painless and mass inoculations, and we have this pellet implantations. So trocar and cannula, and we have DOCA and testosterone. So then we have stylistic, non-biodegradable and biodegradable implants. We have crystalline drugs and leaching and constant blood levels. And we have this hormones, contraceptives and all of that. And intramuscular. We have deltoid, triceps, gluteus maximus, rectus femoris. And with the sensory nerves in the depot preparations for the oily solutions and aqueous suspensions, and we have intramuscular injections, and we have local hematoma. So then we have intravenous, the bolus and intima, and thrombophlebitis and necrosis, and no depot preparations for the heart and the brain, and we have intradermal injections, scarring, multiple puncture, epidermis, drop of the drug, and all of that. So are you clear with the first chapter? So we'll go to the next chapter. So we have pharmacokinetics, membrane transport, absorption, and distribution of drugs. Don't say that you are not familiar with the person who writes this book. You just want to say about things which are meant only for studies, not even a single word other than that. But you must have made sure you make a copy of that and give it to us, so that we don't read books such that like this. So um, like then we have chapter 2. So pharmacokinetics, membrane transport, absorption, distribution of drugs. So Actually, it was a too long time. It's going to be 50 minutes. And so, okay, but like anatomy, we'll be seeing these pharmacology. What is the action of work? And I have to read these entirely such that I become a great doctor. So thank you for your support, and so we'll continue with the anatomy next. So anatomy is very much interesting. Pharmacology is not so boring, but it's very easy. And of course, pathology. I'll be very fast in saying if that I'm saying about it. If I have an idea to say about pathology, but likewise, meanwhile, in a short time, pharmacology is very essential, and so then, but I have never taken 1 hour for one chapter and all. But I'm saying my sorrow about my reading in my second year, so that there are no help to me. So because I don't know, I had no help. So in my house also, we had different language, and we need to talk in Tamil, and we don't speak about medicine. So that also is there, and so. Uh, like what else is that I'll be talking about anatomy. So anatomy fully I'll be dealing. So physiology and biochemistry, I no need to say anything. I think, but only the topics I'll be saying about. Then pharmacology and microbiology and pathology. I just no need to say about it. It's all words and very nice to learn. Except for pharmacology and forensic medicine, these are a must to make a note. And so, thank you.